Hey everyone, my name is Asim Ghazi, and today I'll be discussing our group's work studying how respiratory markers contribute to anxiety detection when using multimodal physiological sensing. What are we speaking of here when we refer to anxiety? Well, in this specific study, we're looking at the anxiety disorder known as specific phobia, where an individual has an intense or irrational fear of a specific stimulus. For example, in the case of public speaking, glossophobia, or in the case of spiders, we have arachnophobia. Now, actually, arachnophobia happens to be the specific phobia looked at in the data set we use in our machine learning experimentation. That said, why is this an important problem? Well, 7.7% of the world's population experiences specific phobia at some point in their life, implying that you likely know someone. What treatment options are available? Well, we have exposure therapy when an individual affected by one of these specific phobia is exposed to the stimulus that they are phobic to physically. You also have virtual reality exposure therapy, where, especially popular at the early phases of exposure therapy, an individual can encounter the specific stimulus that they feel phobic towards in a controlled virtual reality environment, eventually causing habituation to occur, or the person to feel used to the stimulus and not feel as stressed. What's the limitation here? It's difficult for a therapist externally to just observe a subject and truly monitor a person's progress in their exposure therapy when stress is in and of itself a subconscious response to some form of demand. Well, this is where the work that we build upon, IEEE et al., published in 2020, take a look at the overarching idea of using biosignals as some way to provide emotional feedback along with machine learning during virtual reality exposure therapy by classifying periods of anxiety versus rest using supervised learning and the following signals: electrodromal activity, electrocardiogram, and respiratory effort. This is a preliminary step, of course, towards the end goal illustrated here. Now, although they demonstrate promising results in that they are able to classify windows of anxiety versus windows of rest fairly well, one of the conclusions they state was a bit peculiar to us, in the sense that they noted that respiration features did not contribute significantly to anxiety detection performance. We were curious as to how this conclusion came about, because at its core, the acute stress response involves the fight or flight and the rest and digest systems, the sympathetic and the parasympathetic branches of the autonomic nervous system, where both are actually physiologically connected to respiratory physiology, or the lungs, modulating according to the stress response. So that's the theoretical side. Even experimentally, we found in work that's currently under review, respiratory variability markers correlating significantly with underlying neurophysiological responses in the context of traumatic stress. So given these results and the theoretical basis given by the physiological diagram shown here, we thought potentially what we can do is investigate specifically the contribution of each of the signals to the anxiety detection performance to build upon the work of IEEE et al. To better understand whether truly do respiratory variations or respiratory markers have an effect or contribute significantly in anxiety detection performance. And we hypothesize that they do, in fact, improve anxiety classification performance. How do we go about doing this? Well, as a recurring theme, you'll see we use, thanks to IEEE et al., we use the publicly available data set they provide and reproduce quite a few of their approaches, as we will detail further. In particular, the data they make available are the physiological signals detailed here, along with spider clip timings, where subjects are shown 16 different spider clips in a randomized order, and the timings provide reference as to where along these physiological signals these stimuli were actually presented to the individuals. No survey responses were made available, which we will find to be important when discussing labeling later. And 55 subjects had usable data. A few of the example traces are shown here: ECG, EDA, and respiration, courtesy of IEEE et al. Our experiment takes a look at specifically the contribution of each of the signal's features. How do we go about doing that? Well, we use at a high level a rigorous training, validation, and testing approach where we improve upon the work prior, where no data leakage occurs whatsoever. So truly the results we find ensure that we are truly assessing the importance of each of the features towards model generalizability. We use permutation feature importance in the context of the all three signal model. So when using all three signals features, how does each feature contribute to classification performance using permutation feature importance? And then we also take a look at using specific combinations of signals features, meaning, for example, ECG and respiration features, respiration and EDA features, ECG and EDA features, ECG on their own, so on and so forth, all 7 valid combinations. On a low level, how do we go about doing this? Well, we first process each of the 3 signals, as you can imagine, bandpass filtering, so on and so forth, and assess them for quality using state-of-the-art approaches to ensure the legitimacy of our analysis. This is all followed by physiological feature extraction, which involves extracting things like respiration rate, inspiration time, expiration time, their variability, along with ECG and EDA features considered in prior work. These feature time series are then resampled smooth and then windowed into 10-second non-overlapping windows from which statistical features are extracted and a feature matrix for all 55 subjects is formed. Now, for supervised learning, you need some labels. If you recall, no subjective survey responses were made available, so we, again, reproduced the approach of prior work, specifically the HR1 labeling approach or the heart rate 1 labeling approach used to mirror IEEE et al., where the top 5 heart rate increasing clips ranked across all subjects are used, where they're labeled, the windows within those clip timings are labeled as stress, and within the resting phase labeled as rest, 1 and 0. This produced a fairly balanced data set. We have 31 total features, 5 EDA features, 10 ECG features, and 16 respiration features. This summarizes our overall feature matrix. Now, what do we go from here? What's the rigorous approach for training, validation, testing? Well, 5 random subjects are left entirely held out. No training or model selection involves this data, improving upon the approach of prior work. The 50 subjects worth of training data is then in a leave one subject out cross-validation style hyperparameter optimization scheme we find for random forest classification algorithm, again, making sure apples to apples with IEEE et al. The number of trees and the maximum depth are chosen, and then the model or the algorithm is retrained to produce a final model using all training data, followed by testing on the held out subjects data, which we then compile classification accuracy metrics and permutation feature importance rankings. So taking a look at the results one panel at a time, what we see here, the main result we find is that within the top 10 features, 5 are respiratory markers. 4 of them are actually respiratory variability features that were not considered in prior work, but were considered due to our findings of those underlying neurophysiological correlations. When we take a look at the signal-specific classification performances, ECG versus ECG in respiration, significant improvement. EDA versus EDA in respiration, slight improvement, but still noticeable. And then finally, the all-signal model versus just ECG and EDA, again, enhanced generalizability provided when using respiratory features. What do these results suggest? Well, as I just mentioned, contrary to the conclusions of prior research, respiratory features do in fact significantly contribute to anxiety detection performance. We also find from that permutation importance ranking that respiratory variability markers actually should be leveraged then due to the fact that they show up in mass. 4 of the 5 top 10 respiratory features were in fact RPV features. And last but not least, not only does multimodality improve the robustness of an approach. Imagine, for example, if you have an EDA artifact, you have other features that can help back you up. But also they enhance generalizability as shown by our results. Why does this matter? Well, in the context of anxiety detection in general, this paves the way toward improved monitoring of phobic individuals' progress during exposure therapy. And our specific experiments results suggest a reevaluation of respiration sensing's importance toward anxiety detection. Where to next, future work should invest in end-to-end approach so bias is not included in the handcrafted features. Thank you all for your time. I look forward to hearing your questions.